future, maybe we stop to make too many biopsy because we have so many information with MRI, for example, and with a PET scan, the PSMA PET scan, that we probably will do less and less biopsy, and maybe, and I'm sure that it will come very fast, because we are speaking about that, we will do diagnosis of prostate cancer without biopsy, which is today unbelievable, but it's coming. There is some experience on that, and I think it's very important in terms of detection of a disease without using the needle and the complication of a biopsy. This is important. The second thing is we are going also toward making more surveillance, not treating the patient when the lesion is small, because some lesions are not evolving very fast. And today we have more information, because this patient that we are going to survey, to control, to check, maybe this patient sometimes are evolving fast. So there is a population of small tumor evolving slowly, and some patients with small tumor evolving very fast. And today, with the genetics, we know that some tumors are going fast because of the genetics, including the BCR2, which is a good marker today and is known, and it will be a marker for controlling the patient without treatment, because we can predict that this patient will not have very fast evolution. This is, maybe you want to translate or not?
Yeah, after you enter.
After, okay. The other thing is in terms of patients having a large tumor, we know that there is a lot of things in hormonal therapy. We are using now the second set of hormonal therapy earlier. It costs money, but in fact the quality of life and the life experience is better with that. But now it's coming also, we know that for all kinds of tumor, the immunotherapy is coming to be the leader today. In the next future, it costs a lot of money, but it will be really, we know that there is a very impressive results with the immunotherapy. And maybe we'll use immunotherapy as we do for other kind of therapy earlier. That means at the beginning, because you can cure the patient without having any evolution. This will come maybe very fast because of the development of the immunotherapy, a better knowledge of this kind of treatment. This is, I think this is an important point that we will probably discuss during this meeting. And last thing, I think, is the question you ask about the robotics. We know that what you want in surgeries, like in medicine and everything, we want the quality of life of the patient. That means that the patient coming to us, we want him to be cured, to be treated with the better quality of life. For the surgery, we don't want to have hospital stay. We want to have the patient coming and not staying in the hospital. This is important in terms of cost for the hospital, but also quality of life of the patient. Today, we can do a very important surgery without keeping the patient. For prostate cancer, we can do a radical prostatectomy without keeping the patient in the hospital. If the patient is operated in the morning, he can leave the hospital in the evening when the surgery is done in good condition. The robotic allows to do very good surgery because the quality of the surgery with the robot is impressive. That the vision is impressive, but the quality of the movement, the gest, and what the surgeon is doing is absolutely fantastic. And then, for example, on Monday I did a radical prostatectomy before coming. Yesterday I came here. I was quiet because I know that this patient will be okay, and I could accept to come on Tuesday here. And so the surgeon is also quiet because he knows that what he's doing will be precise before. And the quality of life is also for prostate cancer is what is not having any leakage after the surgery, having being cured, of course, and also having a quality of life, sexual life after the surgery. The third point is more difficult because if a patient has a local advanced disease, of course the nurse can be included in the disease, and so the sexual life can be attacked. And but we have treatment, and we have to speak with the patient before that he has to accept that to be treated for having that type of quality of life. So I think the future of the surgery will be robotic. Anyway, at the beginning, 22 years ago, we did the first publication of robotic surgery. During 15 years, everybody was against. But today, I cannot imagine one surgeon not willing to work with a robotic. It's a problem. So there is many competition between the industry of robotic. We know that the Da Vinci is the first one, but today there is other type of robot coming. They are not equivalent. I think the Da Vinci is probably the best. But so it's good to have competition because the cost can be lower and the improvement, even if the new robots are not so good, they will improve very fast because they are in the way of the technology and they are going to be improved. So this is my information. Thank you so much.